like to welcome everyone to our inaugural PHACT series, our public health allied clinician talks. We're really excited to launch this, and we're really grateful for you, each of you, for spending your lunch hour with us today. So our goal was to really strengthen the bond between our public health and our clinical community. We made aware that a lot of our members of our clinical community are not signed up for CIDE and are not necessarily receiving our public health alerts, our advisories. And so our aim is to really give you another touch point with your public health clinicians at the state level, to also have a forum for discussing some really hot topics and topics that are very timely, that we think would be high priority for your clinical care of your patients, as well as give you an opportunity to really share with us what you are experiencing. Our format is going to be pretty simple. We're going to try to give you information in about 10 or 15 minutes, and then for each topic, and then open it up for an open discussion. Share with us, again, your challenges, your dilemmas that you're facing with these issues, as well as if you have resources that you want to share with the clinical community at large. This is a great forum to do it. At the end of the session, we will actually open it up for ideas on what topics would you like us, the public health system, to really flag you on. What should we focus our future talks on? So stay tuned for that. And I would, by way of introduction, I will say I'm Aarti Bans. I'm the Chief Medical Officer at IDPH and an infectious disease physician by background. I'm going to kick off our first topic, which is very concerning, really disturbing in terms of the rise of congenital syphilis in Illinois, with Dr. Maura Quinlan, who is our women's health medical advisor and OBGYN, and has over 30 years of active clinical practice dealing with these issues. And then we're going to move into another topic that's been very disturbing for us. We're starting to see a huge spike in deaths from heat-related injuries in Illinois. And heat injury is not something clinicians are always thinking about. So leading us into that will be Dr. Hilary Spencer, who is our infection prevention medical advisor, as well as a preventative medicine physician, and Graham Briggs, who's our state epidemiologist. So at the end of each session, we will really open it up 10 to 15 minutes of questions. Feel free to ask your questions and chat too, and we will get to them through chat. And we will also unmute participants at the end of each section. So you can ask your question live. Please raise your hands and we will get to you as best we can. So with that, I just want to really talk about congenital syphilis. All right, why are we really talking about this today? So in the past decade, we have watched as pregnant women with syphilis and their babies are really getting impacted by this. Now, transmission of syphilis is really easy to the child, about 80% transmission. To give you just a frame of reference, HIV, untreated HIV, passes to the unborn child about 30% of the time. So there's 30% transmission, syphilis 60 to 80%. And so we really want to raise a call to action to our clinical community. And we'll explain why this is really on us as a clinical care community. And Dr. Quinlan, neither she or I have any disclosures that we need to discuss today. So why now? So we thought we had syphilis in the bag. Back in the 90s, in the early 2000s, we had reached an all-time low. We were flatlined for children in the US being born with syphilis, and that started to change. We started to see in the past decade, more natal females, more women starting to get syphilis. And when women get syphilis, babies get syphilis. And so in Illinois, when we unpack the numbers a little more, just last year, 100 babies in Illinois were born with syphilis. Now, just a reminder, syphilis is 100% treatable. Last year, the year before that, it was 80 children. And to give you an, again, broader frame of reference, a far more challenging um, thing to address is perinatal HIV. Far more challenging to treat, far more challenging to prevent when needed. And we, in the entire nation in 22, we only had 40 babies born with perinatal HIV. And we had 80 just in Illinois. So the question is, what is happening that if we can if we can tackle perinatal HIV and get it down to an all-time low, we should and could tackle syphilis. It is easily treatable. When we started doing a deeper dive into why are we having so many syphilis cases, a large chunk was based on missed opportunities in clinical care. So we are part of the problem, and that is no longer acceptable. We cannot have our children born with syphilis. We really have to address that. And so Dr. Quinlan is going to go a little bit more into those missed opportunities and really talk about how and why and when we need to start thinking about preventing congenital syphilis in our children. So one other thing I just wanted to flag, this is not a Cook County, Chicago issue. This is a Peoria issue. This is a Sangamon issue. This is a Madison and St. Clair. These are where children are being born with syphilis, congenital syphilis too. So it's really important to know for every child that is born with this, there are several more pregnant women with syphilis. For every pregnant person with syphilis, there are several more just reproductive age women with untreated syphilis. And for every reproductive age female, natal female who has congenital syphilis, there are so many more natal males with it. So syphilis is in your community. It's really time for us to start dusting off our instruction manuals on how to deal with this. Just be aware this is in your community, and Dr. Quinlan's going to take us into how and why we can really stop this, at least do our part as clinical care providers. So on to you, Dr. Quinlan.
Okay, let me share. Okay, hopefully everybody can see that. So thanks so much, Arthi. So again, I was in clinical practice as a general OBGYN for a very long time and have been here for a year. And I'm excited that I'm going to be able to pivot a little bit to resources that I wish I had known when I was in clinical practice, resources to help in this, the congenital syphilis space. So all of us in practice kind of remember this from med school, the clinical burden of congenital syphilis, what this means if a pregnant person is not treated. 21% increased risk of stillbirth. We all know that, we're used to doing testing for syphilis when someone comes in with a tragic fetal demise. 9% increased risk of death in the neonatal period. There is a 6% increased risk for preterm delivery. The rate of miscarriage, excuse me, growth restriction goes up. And then we all remember those teeth and bone abnormalities, hearing loss, etc. So lifetime morbidity, again, for syphilis contracted in utero in an untreated pregnant person. So this, as Arthi mentioned, the CDC has these weekly sort of emerging issue maternal mortality or MMWRs that come out, and the one last fall really they did not mince words. They described it as missed opportunities. So congenital syphilis, they made it categorized each case for cases of congenital syphilis, what happened? Why was this person not tested or treated? In the Midwest, they described this as a health systems failure, which I think was, especially when we've looked at cases, it seems like that you can see in this from CDC, this is the Midwest numbers in the box at the bottom. 40% of the Midwest cases of congenital syphilis were in pregnant people who were not tested or not tested in time. So the treatment needs to start 30 days prior to delivery for congenital syphilis to be prevented. 30% though were folks who were tested appropriately and not treated. So this is, if we look just in Illinois, this is our statewide data. And you can see about half the cases are in Chicago. In 2022, 60% of the congenital syphilis fell in the category of testing not done in time or not at all, someone who perhaps wasn't able to get prenatal care till delivery. In suburban Cook, about half of the cases were that no adequate maternal treatment despite timely diagnosis. In the remainder of the state, it's a little bit of an even split. So there is a large number of these cases who had treatment in time and or had testing in time and were not treated. So let's talk about, and again, since I've joined IDPH so many times, I've heard about resources, and I'm thrilled to be able to share this. One of the resources is reporting. So syphilis as a reportable infection, all positive syphilis tests get sent to the STI folks, either in Chicago, if it's Chicago Department of Public Health, if it's in Chicago, or in Springfield, if it's the remainder of the state. And the challenge is it's unclear often if this positive syphilis test is in a pregnant person, because if it is, that gets flagged to get more immediate help with the local health department. So this is a form intended to be done by providers. And I know as a provider, I didn't do the reporting. It was usually done by the lab, but this is for us to do, to report, and it's easy. I did it. It takes about 2 minutes. You put in your patient's info, titer, BDC, etc. So this is a form that will immediately, when you hit submit, it goes to the local health department. And who knew? I didn't until I joined here that they have a whole team to help. All right, so this is the Chicago reporting. They have a little bit of a different system, and there's also a number you can call if you are in Chicago. This is a little bit complicated form that Chicago has to do the reporting for syphilis. So important to know that one of the things that we've seen in these congenital syphilis cases is pregnant people who were tested in outside their prenatal setting and referred to prenatal care for treatment, and that treatment didn't happen. They didn't get access to prenatal care. So we really encourage, it's just bicillin. If they're not allergic, it's safe, it's effective, it can be done in any setting. EDs, urgent care, primary care, sexual health clinics, home administration, we're working on that, and other states have tried to do home administration of the bicillin. So another thing that's really exciting is the perinatal syphilis warm line. This warm line, just to start off, took me a while to figure out it's different than a hotline because the calls are answered in one business day, not necessarily immediately like a hotline. It is an IDPH funded expansion of the perinatal HIV hotline. So those of us who've been in practice remember the early days of HIV. We could call a single number and say, help me, dosing, here's her story, what should I do? Thankfully, the number of perinatal HIV cases in our state have declined remarkably, and that hotline team generously decided to expand to syphilis. So it is a single phone number for providers to call to get clinical guidance when you've got like this patient and her story, you've got a titer, unclear staging. They will help with that clinical guidance, and they can access the previous the records of previous syphilis testing and treatment. So if you're in Oak Park and your patient was treated in Champaign, they can tell you, here was her titer, here's when she was treated, she needs to be treated again or not. So that is a new, it doesn't matter their immigration status, insurance status, you just have to be an Illinois provider because they can't, of course, access easily reports from other states, although we do have some access to our colleagues in other states. So this is another public health entity that I think clinical providers need to know. This is a picture from the NPR report that came out after the MMWR about congenital syphilis, describing disease intervention specialists, which I didn't know those existed, and they do and are a huge help. So the DIS team they're CDC trained community health workers housed in local health departments. Started in the early days of HIV to help with partner notification and treatment, but they can be a resource for us as clinicians if your patient's moved, it's hard to reach them, you're trying to help this treatment happen for them. You can reach out to your local health department and ask for help for the STI division. Some health departments have an official DIS person, some don't, but they all have an STI team or can help you access someone who can help you with care for this patient. When I talked to DIS folks, I asked them what they would like providers to know, and they added that if possible, tell your patient that someone, a public health person, will be calling them, so they pick up. So to access these folks, if you have a patient that's moved or lost a follow-up or trouble accessing this treatment, which, as we know, late latent syphilis is the most commonly diagnosed stage. The treatment is 3 IM bicillin between 5 and 9 days apart. So if she comes at day 10, you've got to start the 3 over again. So if you need help for her treatment, if you look at the IDPH website, it's easy enough to click through and find your local health department. There's a number there. You can call them and ask for the STI team. In Chicago, Chicago Department of Public Health has a main phone line. So future efforts, you know, when we look at these missed opportunities of folks who have been tested, they know they have, we know, they know that they have tested positive for syphilis, but weren't able to access the treatment. One of the efforts is a mobile unit. Is it possible, and they've done this in Louisiana, for clinicians to call the warm line, for example, and say, I have this patient, she really has struggles, life, transportation, childcare, to come 3 times to clinic for these injections. Could we establish a mobile unit in larger cities that could go out to the patient, especially if she's already had her first dose? We know she's not allergic. In the other parts of the state, there will likely be a need for have some enhanced case management, since obviously the van can't go from like Peoria to downstate. The geography doesn't lend itself to that, but so there is efforts to think about how we can help providers who have patients who have tested positive but are struggling to access treatment. Another potential future effort is to expand rapid testing. There are ways to test patients. It does the treponemal specific test, and they could even get a first shot of bicillin at that time. All right, so thank you for all that you do at the bedside, and we appreciate your efforts in this space. And again, that warm line is a great way to start. And I will stop there.
We will unmute our participants now. Please put your questions in chat. I see Mary Beth Stralko has her hand up. Let me see if I can. Mary Beth, would you like to ask your question?
No, I didn't need my hand up. Thank you.
Oh, okay.
No question.
Any questions from this group? Again, I think we really want to emphasize, we have seen too many cases where women have been referred out. I had a 13, 14-week pregnant female who was tested at her prenatal care provider and then referred to an STI clinic. They didn't give her bicillin there. The STI clinic I was working at did not have bicillin because it was in shortage at that time. So please know bicillin is no longer in shortage. But so we had to refer her to a local health department clinic, and I see Dr. Tabidze from Chicago is also on, and she had to make a 3rd trip to a local health department clinic that happened to be closed, the one closest to her. It required 4 trips when she was 14 weeks pregnant to get syphilis treatment. That is not how we do business. We should be doing business. I've seen too many providers not touch and not treat women just because they're pregnant. If they're in the ER, please, penicillin is safe. If they're not allergic, just give them the shot, save that baby. So
yeah.
Go ahead.
And we did a survey last fall for this exact question, and I get it that people are afraid of pregnancy, but this is one area, no fear, it's just bicillin. And some of the sexual health clinics would refer patients to, when we ask them, do you test for STIs in pregnancy? Do you treat? And some of the answers were, we send to the ER. And anyone who works in the ER knows, like, that's not a good use of the ER. It's just bicillin. I know there's a question in the chat about mandatory testing. And there is, I know we all in clinical practice bristle at legislation of our clinical care, but back since in the days of HIV, it became clear in the, whenever that was, late 80s, that the way to increase testing was to make it law. So there is a law in Illinois that syphilis and HIV both need to be tested for at the initiation of prenatal care. A more recent law is that it needs to be, this testing needs to be done in the 3rd trimester, ideally 28 weeks, not with the group B strep, that's too late, but at around 28 weeks, to couple it with your Tdap if you want. So 28 weeks, it's a state law to do HIV and syphilis at that time. So it is law.
And we have another 2 questions. Carolyn, again, if you want to come off mute, feel free. If not, we can read your question from the chat. So if a patient tests positive for syphilis in the ED, whether they're pregnant or not, once the case is reported to IDPH, does IDPH automatically reach out to arrange treatment? Also, if our ED pharmacist calls IDPH, can they get additional information on prior treatment for syphilis if patient does not recall? So the first part, it usually will go, we get automatic lab reporting from the lab. Sometimes it's not often timely just because it's automatic. So eventually it comes into our lab system, and then we send it to the local health departments. The local health departments would then be the ones doing the outreach. But the challenge is, just because someone is pregnant or has syphilis, we don't know if they're also pregnant and that this is a real timely, urgent matter. We're assuming they've already been treated, because penicillin is what you get in regular healthcare systems. You don't need to get it through the health department unless you don't have it. So if you don't have it, that's when you would reach out to the list that Dr. Quillen provided of, reach out to your local health department or the IDPH STI team, and we can connect you to a resource where you can get that penicillin. But it should be in every clinic. So often they have it in the PICSIS and clinics or in the EDs. So the second piece is, does your can your ED pharmacist get prior information? So yes, so if you, most often, if you call that warm line, the number, Dr. William, can you put that number in the chat too? So if you can put the warm line number, you can call it. They will have access to prior treatment. IDPH has access to prior treatment in Chicago. They have access. So if you call Chicago Health Department, and I've done that from the provider end, almost once a week, I've called CDPH or a local health department saying, hey, I have someone here, they're testing positive, what was their last RPR titer? So the health departments have access to that information, can help you determine the stage of syphilis. If they don't have the information, just treat it as syphilis of unknown duration and give the 3 shots of bicillin. Right. Okay, so we have another question from Jennifer. What we are finding is that many urgent cares provide STI testing are not following up to ensure notification of results. It's very frustrating. I agree. Let me make sure I read through your whole. Yeah. So, Dr. Quinlan, any comments on that?
Can I add for Carolyn's question? She asked if IDPH automatically reaches out to treatment. The answer to that is no. But I know those of you who've been in practice know, like, you're in clinic, busy clinic, and your charge nurse comes and says, the health department's calling you, did you treat this chlamydia? So so they will reach out to the provider who reported, not to they won't reach out directly to the patient. However, and the problem is they get so many syphilis tests that are positive, so the health department tries to stratify ones that need urgent attention, like children, or infants. And so if we can say this is a pregnant person, that will ramp up the IDPH reaching back out to the provider saying, how you doing with this? Do you need help? Yeah, the STI, I feel your pain about urgent care not following up. Again, if that's known, the local health department theoretically would reach back out to respond to that positive to see if that if that site had treated that patient. But it's like anything in clinical practice, hard to know who's following up on that. But that would, I'm sure, be so frustrating.
And we put the warm line number in the chat, and I wasn't sure someone was asking for the CDPH number, but we put that number to Dr. Quinnell. Thanks for that. And Joe, so you work at HIV surveillance? Yes, thank you, Joe. So there's a focus only on providers and health departments. We try hospitals, but it's not always easy to, have an access point in terms of hospitals.
I think to answer to Anthony asked about rapid testing, and there is, I think that is the theory, that's what other states have done. Champaign is doing that, if anyone from Champaign is on. The top problem is that rapid testing is not cheap. So the thought is theoretically you could do a rapid, it's treponemal. So if someone has a history of syphilis, it's not going to be helpful. But if someone does not have a history, has a positive rapid, you could give them Bicillin that day. And then try to do the staging from there. So there have been sort of cases and jurisdictions that have tried to do this and done it in cases like needle exchange, some of those settings, and done immediate treatment. The bummer is that then there was the Bicillin shortage, so you're afraid of using it in those settings. But now that that shortage is gone, you could theoretically treat someone that way. And could we do that in pregnancy? Sure, it's a bit of a lift, but that theoretically is certainly possible. The issue is, how do you report to the health department you had a positive that was done as a rapid? But I think there's a lot of room there to expand.
Yeah, and we will be sending a copy out of our presentation once we get our clearance. So any provisional information will be redacted, but we'll send out the links of the warm line and all that information to the registrants.
I can answer too from Amanda why people don't get full STI panels, especially people who are needle averse. They come in for STI testing, and I said, let's just do, I always refer to it as like the blue plate special. Let's just do it all, so you know. And some people say, can I just do the one that doesn't involve a blood test? So doing chlamydia and gonorrhea, or doing, cervical or urine testing for chlamydia, gonorrhea, and trick is obviously much easier at the time of the visit. If the lab isn't open, at Sturgeon, we have that issue. Sometimes the lab folks are gone and the patient's later in our clinic. So I don't think it's providers not realizing that a complete STI screen includes syphilis and HIV. It's just that because it's blood work, it's another step.
We have a question about St. Louis. So in the border area, we do connect if we get flagged. Now, sometimes in the border, we actually get flagged if by the lab if the residence is in Illinois. So we do get notified of results of those who are in others who may have been tested in other states at their residence for reportable conditions. And we usually will connect with other states just to make sure. Now, the challenge with syphilis specifically, unlike say HIV or others, is that the timing, it's a every minute that goes by that we're not able to treat the pregnant person, it's a risk to the baby. So going through usual reporting channels is often the delay. Connecting someone's syphilis test result to the pregnancy status is another intrinsic systemic delay in the system, which is why we need the clinical providers to just be on the ball and say, okay, you have syphilis, we're just going to get you treatment, and then regardless of what jurisdiction they're in.
I can add to that a little bit, that to Adele, that I have learned from the STI folks in Springfield that they do obviously know their colleagues, especially in neighboring states. And we had a really lovely example of that not too long ago, of a woman in Arkansas who tested positive early in pregnancy and moved to, Jefferson County, I think. Somehow the Arkansas health department, that jurisdiction, reached out to the Jefferson County local health department to say, this woman needs treatment. She's not established prenatal care. So they reached out to us. So we were able to give, order the Bicillin for her. So that was a cross-state communication exactly as you're describing. Like, it's not like, well, she's out of here, out of our state, we can't follow, but they know each other. You know, everyone's mission driven, and this person got her 3 doses and it was beautiful. So shout out to Jefferson that they were all about it and made it happen. And she was tested in another state, but it was because of that communication. And the Warm Line has done that. They've gotten calls from Indiana. We're sort of, it's like other states are kind of jealous. So they say, I'm in Indiana, but can you help me? And, you know, as clinicians, you don't want to say, I can't help you, you're not from here. So they'll give some clinical guidance, but they have to tell them, you got to call your health department to get Indiana results. But anyway, it's a tremendous service, and the numbers thankfully are growing in who's calling, because maybe that means that our numbers will go down, hopefully.
Thank you all for this robust discussion. And we have a link up in the chat right at the beginning. And David, if you can maybe put it again, and we'll put it again at the end, where if you have questions and you're shy to ask it, send us. It's a link where you could just really reach out to public health clinician, ask us if you have questions that you're worried that you won't be able to get answered, or it's hard for you to find an answer for. So with that, I'm going to move on to our next topic on heat as we head into the summer. On to you.
This is Hillary Spencer. I'm the Infection Prevention Medical Advisor here at IDPH, and talking to you all about heat with Graham Briggs, our state epidemiologist. So this is, you know, this tagline, beat the heat. And this is really timely this week in terms of thinking about, you know, heat and, you know, weather-related events and the relationship to health is what we want to spend a little time to bring your attention to. So this is Tim Barber. Tim was a healthy 35-year-old from Western New York. It was a hot day in July when he started a new job on a construction site. He came home from his first day of work exhausted and sunburned. He got up early and left the house around sunrise on his second day of work. While at work, he collapsed, and later that day he died of heat illness. He is described by his family as hardworking, an artist, and someone who really loved his family. I wanted to share this story. This is a story that was available on the OSHA, the Occupational Safety Service and a website, because this isn't, you know, this is a healthy person that's robust, and you don't necessarily think about being at risk of heat illness, but really does highlight one of the populations of people who are most at risk. In Illinois and in Chicago in particular, there's a long history, or, you know, a lot of history for heat and the public health response and the impact on health. In 1995, there was a very notable heat wave, and 735 people died. And most of the victims in this heat wave were elderly and individuals who were poor and lacked access to resources. And this is, you know, really highlights sort of the importance of understanding what heat illness can do and who the most vulnerable are. So from the clinical side, what I want you to take away from this are just a few points. So I'm going to start with those up front. First, that story, just to say, like, remember, hold this in your head, like, that this is a risk and who's at risk. So we know that heat leads directly to heat illnesses like heat stroke and heat exhaustion. And in clinical training, that's usually what we learn the most about, what those signs are and how to treat it. That's important to remember, but more so, and from a public health perspective and thinking about prevention, heat contributes to increased morbidity and mortality indirectly in individuals with underlying risk factors. And you can help patients prevent heat injury by recognizing risk factors and creating a plan to stay safe. Now is the time to plan, and for how you and your clinic respond to heat advisories. You can, it's always time in the summer, and outside of the summer, you can, you know, start making plans as well, but we're right in the middle of the heat season. So this is data from the CDC that shows the number of heat deaths. There are about 1,200 heat-related deaths annually in the US, so you can sort of keep that in mind, that 1995 year, where there were more than 700 deaths in Chicago alone, was an unusual year. And we do have those unusual years, and unusual years are happening more and more. Heat-related deaths are happening more and more. This figure shows heat-related deaths by age group. And you can see that that not every age group is affected the same. And I think one of the things to keep in mind with this is that many people can experience heat illness, and heat illness is more evenly distributed, but heat deaths affect primarily, largely middle-aged adults and older adults, and there are different populations at risk at different times. Also keep in mind, this is a figure that shows over time, and you can see that there are some outstanding years, but in every year, men are more affected than women. Men are more likely to die of heat exposure. So that's something to keep in mind as well. So heat illness and the factors that lead to heat morbidity are really complex. There are a lot of factors that go into it. You can't look and identify one factor that may be the only factor that leads to these risks. So there are individual risk factors: age, other medical conditions, pregnancy status, some medications or drugs, cognitive impairments, disabilities. Social isolation is a particularly notable factor. We're learning more and more about the social determinants of health, and that's true for susceptibility to heat illness, and mobility status. In terms of heat exposure, this is also very different in different parts of the country, and it's important to remember, we might think of the Southwest as being particularly hot, but unexpected heat, the humidity that is experienced along with heat, heat amplification, so particularly these urban heat islands, like the measured heat or predicted heat isn't always the same in every sort of microclimate. Occupation is a risk factor. People who are working outdoors or who are working indoors without cooling, or are working with a lot of equipment on. Lack of access to cooling at home, and indoor heat sources. There are many social determinants as well, including poverty, structural and environmental racism, social cohesion, housing status, literacy, and limited worker protection. So different factors to keep in mind as you're thinking about patients who are at risk. In general, the people who are most at risk of heat illness include young children, outside workers, people with disabilities, and older adults. Some additional populations to keep in mind are people who are pregnant, children who have asthma, and again, like the heat can exacerbate some conditions. So not just the direct heat illness, but how like heat may impact those underlying conditions like asthma or COPD or heart conditions, certain medications, and homelessness. In general, people experiencing homelessness are 200 times more likely to die from heat-related causes than sheltered individuals. There are a number of different factors that go into that risk. So I'm not going to go through this whole slide, but this is to say that there are a number of different medications and also substances and illicit drugs that can lead to an increased risk of heat-related illness. So it's something to keep in mind with patients and to counsel on. So keeping that resource at hand and knowing who you may need to counsel, especially if they have additional risk factors. Particularly alcohol can be a major contributing factor in heat illness and heat related deaths. There are a lot of resources as well to help you have these conversations. This is from the CDC. They have a number of different sheets that you can use in terms of thinking about prevention for these different statuses. And this is particularly one for pregnant women. So you can share with pregnant women, especially going into the summer season, maybe a time to do counseling on things that they can do to be aware of their risks with heat. There are similar management sheets that can be used to talk with patients related to heat in children with asthma and heat and cardiovascular disease. So ready-made resources. Another thing to consider is making a heat action plan. So we make asthma action plans and allergy action plans. And in patients who have particular risk factors, you may consider making a heat action plan. So this is geared towards patients, but helping them to think about what are those elements that they may consider in a heat action plan and how to talk with their physician. So how to stay cool, the importance of staying hydrated, recognizing the symptoms. So, making sure that patients are aware of the things that they should be looking for in themselves, how to check air quality, and having a medication plan. These next few slides are showing the heat and health tracker from the CDC. So this is a resource that you can use in clinic or that you can direct patients to use to keep abreast of what's going on in terms of heat illness. Because again, it's often about more than just the number on the thermometer, but the humidity and the microclimate that you're experiencing. So this is a map that shows daily heat related illness. You can see what's affected in different places. This is from last week. And you can hone in on the area that you're in, and you can see this, tank that shows you what the risk is, and sort of boiling it down for patients who are at risk, not just that number, but how to grade that risk. So on this day in Sangamon County, the heat risk was moderate. Another tool that you can use in the clinical setting to help think about a heat action plan and help patients prepare for heat is this acronym Chilled Out. And I won't go through each of the components of that again, but something to think about pulling up. There is an acronym that exists. You can find it. It'll be in the slides too. But to think through those different aspects of making a heat action plan. So what, cooling, what are the access to cooling? What questions do you need to ask? Housing, what are housing issues? What are resources that you may be able to connect a patient to? Isolation, if you know that a patient is isolated, maybe that's the time to pull this out and think about those other risk factors. The first L is for electricity, and thinking about how to access, resources to electricity. If electricity goes out, can they go to a neighbor's? Where are the cooling centers? That kind of thing. Another L for learning, helping patients learn how to access information about what the heat risk is from those previous slides. Drugs, what are the medications, and outside, what kind of time or what is the exposure that the patient has to the out of doors, and how can they modify those risks. So another thing that you can remind patients of are where community cooling centers are. There's going to be different in different communities. This is just a snapshot of cooling centers in Cook County, but patients who are at risk should have that information. They should know where they may be accessing cooling centers in the event of heat, elevated heat. And then lastly, I just want to touch on a few ideas of things that you can do in your clinic. This is a blizzard checklist. I didn't find that there exists a heat checklist for clinics or hospitals. I think that there are some elements from the blizzard checklist that make sense. And I think if we think about the actions that we may take in a blizzard, we could think about similarly, what are some of the actions and how do we want to respond and have the same degree of response for our patients and our clinic when we're having these extreme weather events. So this is just to say, think heat, think what other events there are and how you may want to respond. A couple of things that I was thinking about that a clinic could do, and there's a lot of nuance and opportunity to individualize in your clinic, but notify patients. You might have some high risk patients that you specifically want to notify, or maybe they're coming in. You want to consider rescheduling visits or converting to telemed for patients who may have to wait outside for transportation. Like in the blizzard, we wouldn't be asking people to come in. Similarly, in a heat event, there may be patients that we need to reschedule for. Consider timing of procedures, which may limit mobility. So for those high-risk patients, maybe having, a hip replacement going into that heat event isn't the right time. And flag patients for heat action planning. How do you want to create those heat action plans? And this is just a snapshot from another public health website where there is a heat advisory that pops up. So maybe in your health system, that's something that you want to have pop up. So these are just to say that another thing that comes up a lot in the news is naming these, and there's a lot more attention to this. Should heat waves get names like hurricanes? Similarly to blizzards, thinking about how sort of the degree of impact that these heat events can have, and people need to get riled up about this. So I'm going to hand it over to Graham to talk a little bit about the public health context and where this fits in, where heat fits into our planning in response to climate change and human health.
Very well, thank you, Dr. Spencer. Again, my name is Graham Briggs. I'm the state epidemiologist with IDPH. Some of the work that I do is working on strategies around climate-related health issues in Illinois, and concert with multiple programs across IDPH and with some of our academic partners. So with Hillary talking about heat-related illness today, I thought it'd be nice just to roll that into this larger topic that we're looking into as to how climate is really impacting health overall in Illinois. So with extreme heat, we are seeing some increases in heat-related illness and deaths. I think everyone is aware of that large heat wave that we had over a decade ago with close to 800 deaths related to it in the Chicago area. So this is something that we're continuing to monitor and look for in the state. But we're also seeing changes in our vector ecology. So mosquitoes and ticks and things like that, their habitats are changing, and that includes within Illinois. Some of those mosquitoes and ticks can carry diseases like West Nile and chikungunya, in a variety of different viral and bacterial infections like Rocky Mountain spotted fever and things like that. So as we see these vector insect species changing, we see risk for some of these diseases change as well in Illinois. So we're also seeing a number of different other impacts. Increases in extreme weather events are another example that can put communities at risk for adverse health outcomes. And so it's something that we're trying to really ascertain in Illinois and understand better is how is climate impacting health overall for our population. Hillary, you can go on to the next slide. So I wanted to go over just a couple of priorities today. We've got a number of different areas that we're looking into related to climate and specific to heat in Illinois. And I thought just in the last couple of minutes here, we could touch on a couple of these high level strategies that we're working on within IDPH and around Illinois. So one of those priorities is really increasing the way that we share information with the public. We're looking at getting better at the way that we're pushing information out onto our website, or providing information to others that can make an impact, like this webinar, for example, trying to raise awareness and spread the word about risk that's out there. Heat and cold events in particular are predictable. We all see weather reports, and while weather people aren't perfect, they are getting better and better, and we can predict when we see an extreme heat event or blizzard or that sort of thing coming. And so we also know that risk is directly correlated to these events. And so this is a little bit of a busy graph here, but the blue bars are looking at the number of emergency department visits across the state correlated to our overall heat index in the state, which is that orange or gold line at the top. We can see if we drill into this and look a little bit more closely that as the heat index goes up and as we get over about 105 or so, we really start to see spikes in our emergency department populations related to heat morbidity. And so if we know this is coming ahead of time, we can work on things like messaging and working on prevention and working with our clinical community on preparing for days like this. Same thing goes with cold surveillance on the other side, that if we see a blizzard coming, we know that there's going to be an increase in motor vehicle accidents, hyperthermia, and risk for the population overall. So we want to be aware, of that and be able to share that information proactively with the public. Next slide. The second priority I wanted to talk about today with the clinical community here is we're really trying to increase our community resilience and emergency response capacity in public health related to extreme weather events. So a number of us, including myself, were involved in I guess I'll use the term outbreak of tornadoes the other night in the Chicago metropolitan area. A fair amount of Illinois lies within a large floodplains, and we see risk to populations related to flooding issues. And so we're really trying to increase our collaboration with IEMA and with local health departments to really understand what sort of impact these events have on communities, what sort of needs are in these communities, and look at how we can build that community resilience for these events as they're happening. Next slide. So another thing that we want to be prioritizing here is to better understand extreme weather impacts. And that really goes to the way that we capture and gather and utilize data. So there's a couple of things on this very simple chart that we can take a look at. So we can potentially see that there's an increasing trend with deaths in Illinois related to excessive heat exposure that are noted on the death certificate. But another thing that I also take from this is based on what Dr. Spencer was talking about earlier, seeing that we've got about 1,200 deaths, we think, in the nation on average a year. I wonder if our death reporting is underreported here related to heat. And so these are just cases where heat was specifically listed as contributory on death certificates. And so we're looking at ways that we can increase our ability to understand if somebody has a heart attack, but wouldn't have had that heart attack in their home, which was 104 degrees inside, how heat and other environmental issues are really driving and impacting health outcomes like deaths. Next slide. Then the fourth thing I think, and related to this webinar too, is public health is becoming more and more of a convener as we move into the 21st century and away from providing direct service or direct clinical care as we look at population health issues. And so we can't tackle things like obesity or climate change or some of these other large public health issues without really convening groups of experts to really coordinate together, strategize together, and work together to tackle some of these big community level health issues that we see across the country. And so that, again, is another purpose as to why we're here talking to you today and making ourselves available and hopefully providing some education. With that, I can turn it back to Dr. Barnes.
Great. And again, we will unmute participants. Happy to also take questions in the chat related to heat. Again, we will share these slides with the group. So it might be with those who register. So once we have your registration link, again, in the chat, I'm going to put this in again, is tell us about any future topics you want to hear about, or just put it in the chat and our goal is to really try to make this interactive and address all your concerns that you have as a clinical community. I also put the CDC heat tracker in there. So if you have, again, patients who are sensitive, asthma, and have all these kind of the ones that are in the high risk category, ask them if they're aware about what their heat risk is. And so I think that, again, that heat tracker gives a very practical advice on what to do based on what the heat risk is in that county for that day. So again, if you feel shy, put this in there and we can address any future questions that you have. And also there's a, David, could you, is that the survey link? Let me see if I can put the survey link.
We also welcome if you have other questions about the previous topic, syphilis, or if there are other questions unrelated to either topic that you want to float by. This is a great time.
Okay, so I see people dropping off, and so our next topic we really want to focus on is, and David, yeah, you can unmute participants too, and please raise your hand and we can get to you, is considerations for the fall surge. So it's going to be in August, and we really want to make sure that you know how to deal with the respiratory surge coming up, what vaccines are in the pipeline, what to do for school. So I don't know how many of you have practices that include school-based children, and so we're going to focus on that, as well as statewide standing order. So we have we launched a standing order for undesignated albuterol in schools. So want to guide you through how to think through statewide standing orders and implementing those when they occur. Okay, I see a question in chat. Any news on rapid respiratory illness swab test? Any possible so there, if you're talking about like point of care antigen tests or like a pan respiratory COVID, flu, RSV, Toby, if you want to maybe come off mute and ask us specifically what you mean by the rapid flu, RSV, and COVID. So there is, right now, there are point of care rapid PCR tests. You have to have the machine. They're expensive. Not all have rapid PCR tests in their clinic, but some clinics do have the machines that can run a rapid PCR test for flu, COVID, flu, and RSV.
I just wasn't sure if maybe Abbott wasn't working on a similar swab test that they have been using for COVID that would also do flu or RSV.
You mean like an antigen test?
Yes, it would be wonderful in long-term care.
Yes, and you might be also aware we do have the PCR version that we're offering for free to long-term care facilities through our contract with LabCorp. So certain local health departments and long-term care facilities that deal with the most vulnerable can request and get themselves set up for an account through which we will be able to supply rapid. That's the triple test, flu, COVID, and RSV, but it's
Right.
a PCR. It's not rapid, I should say. It comes back in about 24 to 48 hours. So
both flu and RSV have, there are antigen tests available for point of care use as well. Not necessarily in the triple tests, but there are others available for point of care use too.
Thank you.
Arti, you're muted.
of course, I said again, these questions, feel free to ask. We're here. We are here for the next 3 minutes. So ask away any questions that you have. What do you suggest to workplaces who are breaking heat-related OSHA requirements? So, this is, again, yes, you're right, it's out of our scope, but it would really depend on what the process is for filing complaints with those businesses and who regulates those businesses. So it depends on the type of business. IDPH regulates hospitals, ambulatory surgical care centers, long-term care facilities, a few assisted living facilities. Different state agencies regulate different types of businesses. So it would really depend on what type of business that is. So if it is a healthcare facility, one of that you named, you could always file a complaint with IDPH, and our Office of Healthcare Regulation will take care of it from that standpoint, but that's limited to our jurisdiction.
You can make complaints directly to OSHA as well for many workplaces.
And Dr. Spencer put that link in the chat there. All right, we're down to the last minute. We hope, all right, there's other than syphilis, what infectious disease in Illinois have gone up lately? A lot. All STIs have actually gone up. Chlamydia and gonorrhea have gone up too. So if you're just focusing only on the STI concerns, those have gone up considerably. So thankfully, HIV for the most part has not bumped the same way as others have. Yes, we'll send, so when we send out a shareable version of our slides, it probably won't happen till say Monday. We will include live links in there, as well as the phone numbers for the resources to, again, all our registrants, including those who weren't able to show up today, because we know that, you know, it's a lunch hour. We really appreciate it. One last thing, we will try to, we're in the process of getting CME applications, our applications, so we're hopeful that we'll be able to provide CME in addition to nursing credits and others too for this. Thank you. Thanks, everyone. Appreciate your time today. Take care, and we'll see you again in 4 weeks. Bye.